Rehabilitation Guidelines for Posterior Cruciate Ligament Reconstruction. The knee has three joints: the patellofemoral joint, kneecap, the tibiofemoral joint, and the tibiofibular joint. Joints are named for the two bones that articulate with each other. Most people think of the tibiofemoral joint when thinking of the knee. This is a joint that is primarily responsible for flexing, bending, and extending straightening of the knee. A small amount of rotation occurs at this joint as well. Ligaments are bundles of connective tissue that attach from bone to bone. There are four main ligaments that stabilize the knee. The collateral ligaments are on the inside and outside of the knee and provide side to side stability for the knee. The cruciate ligaments are two large ligaments that cross in the middle of the knee and provide rotational stability and stability front to back. The posterior cruciate ligament is a large, broad ligament that attaches from the back of the tibia and travels forward as it moves up to attach to the femur. Its primary function is to resist posterior translation of the tibia on the femur, especially in flexion. It is also a secondary stabilizer for rotation and varus stability. Injuries of the posterior cruciate ligament (PCL) occurs less frequently than those of the anterior cruciate ligament (ACL). The PCL is tight when the knee is bent, so most PCL injuries occur at that time. The most common cause of PCL tears are sports injuries 37% and trauma 56%. In sports, the most common cause of a PCL tear is falling on a flexed knee. In auto accidents, hitting the upper shin against the dashboard with the knee flexed during an accident, dashboard injury, is the most common cause. Immediately after the injury, it is common to have a swelling in the knee, general knee pain, and a loss of motion. It is often difficult to predict the long term outcome of PCL injury. Some patients show significant symptoms and subsequent articular deterioration after a PCL injury, while others are essentially asymptomatic and maintain normal function. Evidence from randomized controlled trials to determine a single treatment of PCL injuries is lacking. Observational studies suggest that isolated PCL injuries may be treated conservatively with good prognosis. Shelbourne treated 22 isolated grade 1 and grade 2 PCL injuries with extension bracing for 6 weeks. In Shelbourne's study, 19 of the 22 patients went on to show healing by MRI and demonstrated stability. Bracing is primarily effective when it can be started within 1 week of injury. Surgical reconstruction is needed for patients with PCL injuries that are combined with other ligament injuries in the knee, combination injury or multiligamentous injury. Isolated grade 3 injuries or PCL injuries with chronic instability. Patients with chronic instability rarely suffer complete giving away episodes. More often, it is a general sense of instability with pain in the front of their knee, especially with running or stair climbing. Posterior laxity can be assessed with a posterior draw test, the dial test, or a KT1000 test. Although laxity is not directly correlated to instability, surgical reconstruction is done by replacing the torn PCL with a graft. This graft can be single strand or bundle of tissue or two strands, double bundle. Grafts can be taken from areas of your own body, autograft, such as the patellar tendon, or from cadavers, allograft. To date, there have not been significant differences in outcome studies comparing the various graft choices. Figure 1: posterior back view of the knee with the PCL shaded in red. The grafts are placed and anchored in tunnels drilled in the femur and tibia. The rehabilitation process begins the first weeks after surgery. During the first 4 weeks, weight bearing and range of motion are limited to protect the healing of the graft. Hamstring exercises are also avoided because the hamstring pulls the tibia posteriorly backward, which would cause stress to the healing graft. In phase 2, patients will begin to work more aggressively on strength and range of motion, usually discontinuing all use of the brace by 6 weeks. Prior to returning to sports, patients must regain strength, movement control, proprioception, and force control. This often involves several months of progressive rehabilitation exercises. The rehabilitation guidelines below are presented in a criterion based progression. Specific time frames, restrictions, and precautions are given to protect healing tissues and the surgical repair or reconstruction. General time frames are also given for reference to the average, but individual patients will progress at different rates depending on their age, associated injuries, pre injury health status, rehab compliance, and injury severity. Sagittal view MRI demonstrating a normal PCL. Sagittal T1 MRI demonstrating a torn PCL. Phase 1, surgery to 4 weeks after surgery. Appointments, physician appointment 1 to 2 weeks and 4 to 6 weeks after surgery. Rehabilitation appointments begin 1st to 3 days after surgery, 2 times per week. Rehabilitation goals: protection of post surgical knee, restore normal knee extension, eliminate effusion, restore leg control. Precautions: weight bearing as tolerated, use pain and gait as guides, must wear the brace for all weight bearing activities, progress from locked to unlocked when patient has good quadriceps control, use auxiliary crutches for normal gait, no open chain hamstring strengthening or isolated hamstring strengthening, no hamstring stretching, no bike, follow range of motion guidelines. Range of motion exercises: 0 to 4 weeks, full extension to 90-degree flexion, extension, knee extension on a bolster, avoid prone hangs secondary to hamstring guarding, flexion, use gravity or assistance to minimize hamstring injury, activity such as supine wall slides or seated knee flexion. Suggested therapeutic exercise: quadriceps sets, open chain, knee extension against gravity, straight leg raises, leg lifts in standing with knee brace on for balance and hip strength, avoid hip extension 2-degree to hamstring restrictions. Cardiovascular exercise: upper body circuit training or upper body ergometer. Progression criteria: pain free gait using brace without crutches, no effusion, knee flexion to 90-degree. Phase 2, begin after meeting phase 1 criteria, usually 5 weeks after surgery. Appointments: physician appointment 8 to 12 weeks after surgery. Rehabilitation appointments are 1 to 2 times per week. Rehabilitation goals: single leg stand control, normalize gait, good control and no pain with functional movements. Precautions: discontinue brace weeks 4 to 6 as the patient gains leg control and balance. No open chain hamstring strengthening or isolated hamstring exercises. No hamstring stretching. No bike. Follow ROM guidelines. No forced hypoflexion. Range of motion exercises: weeks 5 to 6, full extension to 120-degree flexion, gradually attain full flexion, avoid forced flexion. Extension, knee extension on a bolster, avoid prone hang secondary to hamstring guarding. Flexion, use gravity or resistance to minimize hamstring activity, such as supine wall slides or seated knee flexion. Suggested therapeutic exercise: quadriceps strengthening, closed chain exercises short of 70 degree of knee flexion, non-impact balance and proprioceptive drills, gait drills, hip and core strengthening, stretching for patient-specific muscle imbalances, cardiovascular exercise, upper body circuit training or upper body ergometer, progression criteria, normal gait on all surfaces, ability to carry out functional movements without unloading affected leg and without pain while demonstrating good control, single leg balance greater than 15 seconds, full ROM. Phase 3, begin after meeting phase 2 criteria, usually about 12 to 16 weeks. Appointments: physician appointment 3 months after surgery and 4 months after surgery. Rehabilitation appointments are 1 to 2 times per week. Rehabilitation goals: good control and no pain with functional movements, including step up or down, squat, and lunge. Good control and no pain with light agility and low impact multi-plane drills. Precautions: no open chain hamstring strengthening or isolated hamstring strengthening. Suggested therapeutic exercise: quadriceps strengthening, closed chain, progressing to multiplane and open chain exercises. Non-impact balance and proprioceptive drills. Impact control exercise, beginning 2 feet to 2 feet, progressing from 1 foot to other and then 1 foot to same foot. Movement control exercises begin with low velocity single plane activities and progression to higher velocity multi-plane activities. Hip and core strengthening, stretching for patient specific muscle imbalances. Cardiovascular exercise, upper body circuit training, progression criteria, normal gait on all surfaces, ability to carry out multi-plane functional movements without unloading affected leg or pain while demonstrating good control, ability to land from sagittal, frontal, and transverse plane leap with good control and balance. Phase 4, begin after meeting phase 3 criteria, usually about 24 weeks. Appointments: physician appointment 6, 9, and 12 months after surgery. Rehabilitation appointments are one time every 2 to 4 weeks. Rehabilitation goals: good dynamic neuromuscular control and no pain with sport or work specific movements including impact. Precautions: post activity soreness should resolve within 24 hours. Avoid post activity swelling. Suggested therapeutic exercise: sport or work specific balance and proprioceptive drills, progress impact control exercises to reactive strengthening and plyometrics. Incorporate running program as appropriate. Continue quadriceps strengthening, hip and core strengthening, stretching for patient specific muscle imbalances. Cardiovascular exercise, replicate sport or work specific energy demands. Return to sport work criteria, dynamic neuromuscular control with multi-plane activities without instability, pain, or swelling. Thank you. Subscribe for more content.